Welcome to the wonderful world of gastroenterology. And the main structure in this whole block is going to be your gastrointestinal tract, your GIT. So let's just talk about that. Your tract, your GIT is just one long tube from your mouth to your anus. It helps us digest, absorb, and move food. Let's draw it out. Here's your mouth, here's your pharynx, and you'll eat food, and that'll go down your esophagus, and your esophagus will eventually lead to your stomach. Your stomach is well known for producing acid, helps us break down that food, and all that will eventually lead into your small intestine. That includes your duodenum, and that includes your jejunum and your ileum. I'll draw it like this, all right? It's not physically accurate, but you know what I'm talking about. So that's your small intestine, and that will break down, digest, absorb some food. And your small intestine will lead into your large intestine. We call it the large intestine because it's quite large. And your large intestine will again help you break down food and also turn it into its final product, which is poo. And you'll eventually poo it out. And that is the function and the structure of your gastrointestinal tract. Hopefully that's not too bad. Now the wonderful thing about your GIT is you don't really have to control it. It kind of moves on its own, kind of digests things on its own, kind of absorbs things on its own. You don't have to consciously control it. You don't have to say, oh, now I have to move food from my stomach to my small intestine. No, you don't have to do that. It does it on its own. How does it do that? Well, during development, neural cells will come down from your brain and migrate down to your GIT and make its own nervous kind of system. We call it the enteric nervous system. And so it kind of has a mind of its own. So if we look at the tube closer up microscopically, this is our tube, then we can look at the layers of the tube and kind of see these neural cells. So we'll start with the innermost layer. The innermost layer is going to be your mucosa. Mucosa. And your mucosa consists of your inner epithelium. So, all right, epithelium. It'll include the connective tissue underneath it. We call that the lamina propria. And then last but not least, there's a special kind of muscular layer in your mucosa. We call that the muscularis mucosa. Muscularis mucosa. Underneath the mucosa is your submucosa. What a fitting name. You have your submucosa. And your submucosa will contain some of these neural cells and form what we call the submucosa plexus. The submucosa plexus. And the submucosa plexus helps us secrete things. We need to secrete a lot of things, as you can imagine. So it just helps us secrete things. Again, all on its own. We don't have to think about it. Underneath your submucosa, you have this stronger muscular layer called your muscularis externa. And here you'll see some more neural cells. And these form a plexus called your myenteric plexus. Myenteric means related to the muscle, so it's in your muscularis externa, isn't it? So myenteric plexus is related to the muscle because this is what helps it move food. It can cause your GIT to squeeze and move, and that helps us move food. Last but not least, our most external layer is just going to be kind of an outside protective coat. And if it's in the peritoneum, if it's intraperitoneal, then the peritoneum will form the coat of it. This kind of serous membrane called the serosa. And I'll write if intraperitoneal. If it's in the peritoneum. If it's not in the peritoneum, then the peritoneum won't be able to form the serous membrane, won't be able to form the serosa. So we can't call it serosa. So if it's retroperitoneum, if it's behind the peritoneum, then we call it the outside layer adventitia. So right, adventitia if peritoneal. Those are the layers of your gut. And since we're talking about microscopic imaging, let's talk about histo. So if we take a histo look at, we'll start from the top. If we take a histo look of your esophagus has to deal and move food. Sometimes that food is sharp. Sometimes that food isn't so nice to it and it can cause abrasion, and we don't want that. We want a protective epithelium. What's our most common protective epithelium? We use stratified squamous. Stratified squamous. Is it keratinized or non-keratinized? Well, the only keratinized stratified squamous you see is on your skin, because your skin has keratinocytes that make keratin. This is not your skin, so it's going to be non-keratinized. Non-keratinized. Move on down to your stomach. Your stomach churns out acid. So some peculiar things you'll see on histo is going to be gastric glands that make acid. Your duodenum does a ton of digestion and absorption, like a ton. Like it's the main part. So in your duodenum, you'll see a lot of villi and microvilli, which help absorb and digest. You also see Brunner glands or Brunner glands. What are these? These make bicarb. Why do you need bicarb? Well, we just said your stomach makes a ton of acid. And when it releases that acid, if you don't have something to neutralize it, it'll burn a hole right through your duodenum. So your Brunner glands, your bicarb help kind of neutralize the acid. And then we move from your duodenum to your jejunum, which, sorry, jejunum, there's nothing really important about it. So we'll move from your jejunum to your ileum, and your ileum is very important because your ileum has something called Peyer's patches. These are lymphoid aggregates that you'll be able to see on histo. And they have a ton of cells that fight baddies, and make IgA, because we're talking about mucosa stuff. IgA is the main antibody in the mucosa. Ileum has your Peyer's patches. It also has the most goblet cells. Goblet cells help make mucus. Why do we need mucus? Well, we need to lubricate the food, the poo, and help kind of ease its passage. So it has the most goblet cells. So ileum is incredibly important to know. And then lastly, your large intestine, your colon. It'll continue to have those goblet cells because you need all the lubrication you can get. But the villi will start to disappear because you don't really absorb too much things in the colon. Your colon's basically, everything's already done. It's just there to move the poo around. Some things you do absorb, you'll kind of reabsorb some water, kind of solidify and harden the poo. But other than that, the villi disappear. So villi are gone. That's how your GIT looks grossly. That's also how it looks microscopically. Comprende? Hopefully that's not too difficult. Now, how do you form your GIT in the first place? It's quite a loaded question. You see, if you stretch your gastrointestinal tract all the way out, it's about 30 feet long. It is very, very long, but it can fit just in here. How's that possible? When you're an embryo, let's talk about embryology. When you're an embryo, you'll start making this tract. You start making this tube. And here's the problem. You're such a small little embryo and this is growing at such a rate that it's too big to grow inside your body. So the middle part of this tube will actually blow out of your umbilical ring. Blow out of your umbilical, just shoot out. And this happens about the 6th week. So during the 6th week, the middle of your tube, the middle of your gut, we call that your midgut, will leave the umbilicus. That's pretty wicked, isn't it? So it'll blow out and start to kind of develop. And that way you have a little bit more space, okay? And when you're 10th week old, when you're a 10-week old, you're a little bit bigger. All right, so you can accommodate that growing tube, and that tube will come back in. That's pretty wicked. So during the 10th week, your GIT will come back in. So I'll say, come back in, And it will rotate around the superior mesenteric artery, your SMA. Rotate around SMA. Kind of rotate itself around the gut. That's why it's so curly. So curly, and then settle, continue to develop, and you have your GIT. All right, so that's how 30 feet of tubing can fit in us. It didn't fit in us originally because it kind of blew out, but eventually it'll come back and fit inside of us. All right, so if we're making this tube and the middle part blows out, then kind of by definition, we have 3 parts of the tube. We have your middle part of the tube, your midgut, and we have this part, the part of the GIT, the part of the gut that comes before it. We call this your foregut. And then we have this last part, don't we? The part that kind of comes on the hind end, we call that your hindgut. And lo and behold, we have 3 parts of our GIT. So your foregut will eventually become everything from your pharynx to your proximal duodenum. Let me color code this. Orange will be our foregut, okay? So pharynx, everything down to your proximal duodenum. Now, not only your proximal duodenum, but include accessory organs that help us digest and absorb food, like your liver and your gallbladder and your pancreas. Wait a minute. I understand how all of this came from this tube, but where the heck did your liver and your gallbladder and your pancreas come from? Well, during development, the proximal duodenum will start to bud out. It'll start to make these buds. And these buds will eventually become your liver and your gallbladder and your pancreas. All right, so it's still part of your tube. Okay. We'll talk about more about this development in our next video, but just know that it's still part of our foregut. Your midgut, we said, blows out, and your midgut will include your distal duodenum and 2/3 of your transverse colon. The particular anatomical landmark that they want you to know is going to be your splenic flexure, your left splenic flexure. So this will be your distal duodenum, including your entire small intestine, and then your 2/3 of your transverse colon all the way to your left splenic flexure. That is all midgut. And then lastly, we have our hindgut. Your hindgut is going to be everything else. That's easy enough to remember. Hindgut is everything else. Hindgut. So that includes your last 1/3 and then everything, the rest of it. To your pectinate line. Your pectinate line. What the heck is your pectinate line? I'm not going to tell you that yet. That's called showbiz. I'm going to keep you on the edge of your seat. We're going to talk about the pectinate line in a second. But I think the first thing I want to talk about is the blood supply. The blood supply to all this. The blood supply to all this, your abdominal organs, is going to be from your abdominal aorta. Your abdominal aorta will go down your abdomen, and there'll be branches of it to help supply all of this GIT. What supplies your foregut is going to be your celiac artery, or your celiac trunk, and all of its branches. What supplies your midgut is going to be your SMA. Isn't that the artery that it wrapped around? Isn't that like his best friend, the SMA? Absolutely right. SMA. There's something you should be aware of. It's called SMA syndrome. It wraps around and is very close to your SMA, but there's a little pad of fat that kind of cushions it between your gut and your SMA. And sometimes if you're really malnourished or you're anorexic, then that fat can disappear and your duodenum can compress on your SMA. And every time you eat food, it will enlarge and compress on your SMA and you get pain. That's SMA syndrome. SMA syndrome. So I'll say pain after food due to decreased fat. Anytime you have pain after food, there's a few differentials. If the patient is overweight, then you can think of gallstones. Every time they eat, gallstones will try and get released and to get pain after eating. If they have a history of things like cardiovascular disease, and you can think of like ischemic colitis, where their vessels are blocked by plaques, and every time they eat, they feel pain. But those are all overweight people. If they're underweight, if they're anorexic, the history of malnutrition, then you're thinking of SMA syndrome. All right, so easy to differentiate. All right, that was a little tangent. Let's go back to what we're talking about, blood supply of our GIT. What supplies our hindgut? It's gonna be our last artery. That's our IMA. IMA. Those are our blood vessels of our GIT. They might be really nitpicky and say, well, what's the nerve supply of our foregut, midgut, hindgut? That's, if you need to know that, I got you. So we can break up the nerve supply by parasympathetic, sympathetic. Parasympathetic of your fore and your midgut is going to be your vagus nerve. It's kind of the main rest and digest nerve, your main parasympathetic nerve. So your hindgut is a little bit different. Your hindgut gets its parasympathetic innervation by your pelvic nerve. That kind of makes sense because it's kind of lower, it's near your pelvis. Sympathetic, again, our foregut and our midgut kind of share something, and that is going to be your thoracic splanchnic nerves. And then your hindgut, because it's kind of further down, it's going to be your lumbar splanchnic nerves. That's if they're really nitpicky. I want you to know the nerve supply. But hopefully they don't do that. And that finishes our talk on the supply of your GIT. Now I hinted about the pectinate line. Let's talk about the pectinate line. What's the pectinate line? Your pectinate line is very important because your gastrointestinal tract isn't exposed to the outside of your body. Your anus isn't like coming out of your body. It's actually, it stops it in short. Yeah, it stops it in short. So it stops it in short. And then everything below it is going to be your outside skin. It's kind of protecting us. And then everything above it is going to be our gut, or GIT. And that line separates our endodermal GIT from our ectodermal skin. And there's very important things that go on here and some anatomical things you should learn about. So we'll talk about the pectinate line. Pectinate. Above the pectinate, we said, is your GIT, your hindgut. Above equals hindgut. So blood supply of your hindgut is going to be, if you say IMA, absolutely right, good. Sometimes I want you to know the exact branch that supplies this area, and that's going to be your superior rectal artery. What's going to be the venous drainage is going to be your superior rectal vein. Venous superior rectal vein. And that will eventually lead to your inferior mesenteric vein and eventually lead to your portal vein. So all GIT drainage basically, because it's part of your GIT. Some pathology that can occur here. Constant strain and constant constipation can cause small veins to dilate. we call these hemorrhoids. And because they're inside the pectinate line, because they're internal, inside your body, we call these internal hemorrhoids. Internal hemorrhoids. And the thing you should know about internal hemorrhoids is that the nerve supply is visceral. It's not painful. It's all right, not painful. You can also have cancer here, and because we're still in the GIT, we still have a lot of those goblet cells, those mucus cells, yeah, those glands. So if you have cancer of these glands, isn't that adenocarcinoma? Adenocarcinoma. If you have adenocarcinoma, then it can spread to your lymph nodes. And the lymph nodes that supply this area is going to still be inside your body, internal lymph nodes. And these in particular are going to be your internal iliacs, internal iliac nodes. That's all above the pectinate line. That's still talking about our gut. What's below the pectinate line? This is below the pectinate line is basically your outside skin, your perineum, perianal area. Yeah, it's your outside skin. It's kind of the area around your butt, basically. Your perianal area. So all right, below. Perianal. And your perianal perineum area is mostly supplied by your pudendal nerve and your pudendal blood supply. So I'll just write pudendal. So if we're talking about blood supply to this region, we're going to be talking about your pudendal artery. Pudendal artery. Again, if they want to know the exact branch, it's going to be your inferior, as opposed to your superior, your inferior rectal artery, because it is below. It kind of makes sense. If they want you to know the venous drainage, then it'll be your inferior rectal vein, and that's draining to your pudendal vein. So inferior rectal vein, and then it'll go to your pudendal vein, and then go to your iliacs and your IVC. Yeah. Now some pathology. Some pathology. You can have dilation of veins here. And because these are outside of your body, these are external hemorrhoids, external. And they're supplied by your pudendal. Sensation is supplied by your pudendal nerve. And this is going to hurt. External hemorrhoids, because they're supplied by your pudendal, are going to hurt, equals hurt. All right, so these are going to hurt. You can have a fissure here. This is when you have a skin break, basically. And it's often the posterior portion of your anus. So I'll write posterior because the blood supply to your posterior portion isn't that good. So just know fissures are more common in your posterior portion. And when you have a skin break, then you'll have bleeding and you'll have a lot of pain. And so it's common in children, they'll strain and then they'll kind of complain of pain, and you'll go and wipe and they'll see there's blood streak on the toilet paper. So I'll write blood streak on toilet paper because you're wiping that skin break on toilet paper. Pain on the posterior region, that's a fissure. You can have cancer in this region because you're having cancer of the skin, your squamous cells. You can have squamous cell carcinoma. And that can spread to your lymph nodes. The lymph nodes are not going to be inside your body because we're no longer talking about internal, we're talking about external. So the lymph nodes are going to be spread to your external nodes, in particular your inguinal nodes. Those are the nodes kind of in your inner thigh, your inguinal region. So these will spread to your inguinal nodes. Got it? Good. That's your GIT. That's a lot messier than I really thought it'd be, but hopefully you understand. Our last topic before we close it all out is going to be on ligaments in your GIT. You see, you have all these structures, all these nice structures, and they have to be held in place, otherwise they'll just kind of wiggle around. So they have to be held in place, and in particular, we're going to look at this region. This region. All these things have to be held in place through GIT ligaments. So let's talk about these ligaments. Let's draw this. Let's kind of blow this up and draw this in a little bit more detail. So we have our esophagus leading to our stomach. And our stomach will send food to our duodenum. And that goes to our jejunum and our ileum, eventually to our large intestine. Our large intestine. And eventually out. Okay? We'll draw also our accessory organs of GIT. So we have our liver, our nice friendly liver. And we have our gallbladder kind of tucked inside of it. All right, I think we'll stop there. So ligaments have to hold everything in place. And if you ever seen the liver straight up, you'll see there's kind of this ligament that's right in the front of it, right in front of the liver. And that ligament is called your falciform ligament. Falciform ligament. And the reason it's right in front of your liver is because it attaches the liver to your front anterior wall, your front abdominal wall. So, all right, attaches liver to anterior abdomen. That's not enough that you know it attaches the liver to the anterior abdomen. You should also know it contains your umbilical vein, remnants of your umbilical vein. Didn't your umbilical vein travel past your liver? Hopefully you remember that from our cardio block, didn't it? And so you still see remnants of that umbilical vein. Next thing you have is your hepatoduodenal. This links to your liver to your duodenum. Liver to your duodenum. I'm drawing a different color. And it can take up the nutrient-rich blood, and it can also release bile. Yeah, and that's one of the main purposes of your liver and your gallbladder. It can release bile. And we call all this the portal triad. Portal triad. So the blood part of it is going to be things like your proper hepatic artery and your portal vein. And the bile part of it is going to be your bile duct, common bile duct. Okay. Something you should know, I guess is a little bit of a surgery tie-in. If you want to control the bleeding, all you have to do is take your fingers and pinch that ligament. And that is called the Pringle maneuver. I've seen questions on it. They'll talk about someone's doing gen surge and they're cutting and then they spring a leak. There's a blood vessel bleeding. And they'll take their finger and they'll clamp on this hepatoduodenal ligament and the bleeding will stop. And then they might ask, well, what vessel is bleeding? Look for these vessels, okay? In the answer choices. That's the Pringle maneuver. Very important you know that. So that links your liver to other things, your abdominal wall, your duodenum. Let's talk about your stomach. Just a little recap of stomach anatomy. We're going to talk about the stomach in depth later on, but this is just a recap. The small curvature is going to be called your lesser curvature, and it contains your gastric arteries. These arteries out here are called gastric arteries. This greater curvature is going to be called your greater curvature, and these contain your gastroepiploic arteries. Epiploic means related to the omentum. And remember, your omentum is this sheath that kind of covers everything. And so it's a fitting name, gastric epiploic arteries, because it's your stomach and your omentum, gastric epiploic arteries. So your stomach needs a lot of ligaments to attach to things. One of them is going to be your gastrohepatic. What do you think that attaches? Your stomach to your liver, right here. So it attaches your liver to the lesser curvature. What blood vessels do you think is going to be here? What will be your little gastric arteries? Gastric arteries. You'll also have another ligament called your gastric colic. And this attaches your greater curvature to your colon. Gastrocolic. So greater curvature to your transverse colon. What vessels are you going to find here? It'll be those gastric epiploic arteries. Gastroepiploic. Last but not least, I didn't draw it out, but here's your spleen. You can attach your stomach to your spleen. We call this splenic. Fitting name. Now the arteries here is a little bit different. It kind of splits the difference between your gastric and your epiploic. And so it'll have some from your gastric, in particular your short gastric. So short gastric. And it'll have some arteries from your epiploic, mainly the most left, because it's the left side of your body, the most left one. So your left epiploic, gastroepiploic. And those are the ligaments that hold your GIT in place. Now there's one more in first aid. I don't know why they put it there, but we'll go over it for completion. It connects your spleen to your back abdominal wall. You see your spleen is intraperitoneal, so it'll connect it to your back abdominal wall, and that's going to be called your splenorenal ligament. And it'll contain all the blood vessels that supply your spleen. So it'll contain your splenic, artery, and your vein. It'll also contain something, because it's in the vicinity, it'll contain the tail of your pancreas. Tail of pancreas, plus tail of pancreas. It contains the tail of pancreas because it's in your vicinity, and also because it's the only part of your pancreas that is intraperitoneal. Okay? So it kind of contains that too. And that does it for this video. That does it for our first video on gastroenterology. Hope you enjoyed. Thanks.